Okay, we're going to go ahead and get started. I hope everybody can hear okay. If not, you can type into the chat box if you're on GoToMeeting and let us know. My name is Matthew Smith. I'm a pediatric neurosurgeon at Washington University in St. Louis, and I work mainly at St. Louis Children's Hospital, and I'm interested in pediatric epilepsy surgery. And I'm here with a couple of my other collaborators in this effort for stereo EEG, a new program we started here about a year ago at St. Louis. Here's John Zempel to introduce himself.
My name is John Zempel. I'm a pediatric epileptologist. I've been here at Washington University for the past 30 years in one form or another, and we have an active group of 9 pediatric epileptologists as part of our team, and a whole bunch of other important people who are key to making this work, including the next speaker, Michael Morrissey.
Michael Morrissey. I've been with this group for about 10 years. I'm the technical director of the lab, but I help work the pre-surgical evals and help with just dealing with the data of our invasive cases.
So we're here in St. Louis, flyover country, and none of us have any disclosures relative to the technologies we'll be discussing today. So this introduction of this stereo EEG comes out of some emerging concepts that apply to resective epilepsy surgery. The idea over the past 10 or 20 years where we've been using multiple modality imaging to optimize planning and outcomes, and we're evolving towards more minimally invasive strategies. For example, not just SEEG for less invasive electrode implantation, but using things like Montage and visual laser ablation therapy. Traditionally open neurosurgical procedures now have variations that utilize endoscopes to make smaller incisions and do less invasive surgeries, such as endoscopically assisted callosotomies or endoscopically assisted hemispherotomies. And the use of energies such as stereotactic radiosurgery, gamma knife or cyberknife to treat epilepsy lesions or RF ablation. So we seem to be evolving towards smaller, less invasive procedures, with the idea being that perhaps we can disrupt these networks and that smaller interventions over time may be more effective and potentially less risky to the patients. And there's also the concept that surgery, we don't always have to swing for the fences. The impact on seizures is the goal, and we may be trying for seizure reduction in some cases and improvements in quality of life, not just seizure freedom. Here in Missouri, there's a population of approximately 6 million, and you can distill out of that potentially 3,000 surgical candidates in the pediatric population. So these are the patients that we're focusing on. The difference between SEEG and open craniotomy is, as you can see on this slide here, it's a big difference. Instead of a big, large opening with the traditional grids and strips, we're doing small 2mm twist drill holes and placing these percutaneously.
So SEEG is changing our concept of how we treat and identify epileptogenic networks. And there's been a constant tension between those people who believe that epilepsy is a local network problem and a more widespread network problem. And SEEG is allowing us to explore these ideas in much greater detail. The use of SEEG requires more thought in some ways and more strategy than with grid-based techniques. And both the ROSA software and the robotic assistance allows us to get electrodes where we couldn't possibly think about getting them before. It's changed the way, and we'll present some of this detail in this webinar, how we think about mapping and monitoring. And one of the big changes is when we've typically done grid-based resections, it's been a single hospitalization, very intense for the patient, whereas now patients we can get their data, get their seizures, do the mapping, and then they can go back home and we can talk about in more detail under less pressure with these families what the options might be. There's a nice body of literature that supports doing stereo EEG in children. Our colleagues in Europe have been much more aggressive over the past decades in using stereo EEG. So there's some nice outcome data on children who have had very difficult epilepsies and that SEEG can be very helpful as part of their evaluation. In addition, in the United States, the Cleveland Clinic, which has been very active on the pediatric and adult sides, has shown that in children with very difficult to localize drug-resistant epilepsy, that reasonable outcomes can be attained with SEEG technology. So some of the advantages of stereo EEG are we can place electrodes deep into the brain where we could not have imagined putting electrodes as easily before as with grid-based operations. We've had electrodes in the insula, the opercula, and all along the cingulate. And having these monitoring points is both important for knowing what might be happening, but also as in a particular epilepsy network. But they also reassure us, because these are major nodal points in brain anatomy, that seizures that pass through these, that we're really seeing the start of a seizure rather than seeing propagation. We're seeing some really important networks come out and being important in epilepsy, and I suspect that surgical failures in the past may have been due to lack of consideration of all these propagation networks. And as anyone who's been through an SEEG operation with a child and a family, this is simply so much better tolerated compared to grid-based technology. There's still some significant challenges of stereo EEG, and when we put an electrode in, we're not sampling from the same type of contiguous cortex that we were able to with grid and strip-based techniques. A syndrome that's arisen named out of this is what epileptologists feel when we don't have this contiguous coverage, called the missing electrode syndrome. You know, we want to figure out how to define the margins, and we don't have that kind of definition. So picking your spots for electrode placement and understanding where surgical resections can be made is key part of these considerations, particularly in planning.
And there are some technical challenges with SEEG, some that apply to adults and some to children. With respect to children, and in some portions of adult skull, there is a minimal thickness of the skull that's required to safely hold the anchor bolt, and it's approximately 3 millimeters. And when we put these complex intracranial arrays in, we can end up coming out with data that suggests fairly complicated regions for resection or ablation that can be more challenging than just an anterior frontal lobectomy, for example. And then we're always worried about complications, the main one being hemorrhage with electrode passage, and we'll talk a little bit about that later when we get to the technical details of how to place the electrodes. And then the electrodes don't always go where we point them, either due to registration errors or due to physical characteristics of the bone, dura, or brain that might deflect electrodes from your intended target. So our protocol for pre-op evaluation for potential SEEG patients is similar to our grid-based paradigm, in that all of the data is discussed in a multidisciplinary epilepsy conference. And then additional surgical options are considered, but if patients are referred or voted upon for an SEEG implant, then the primary epileptologist will help outline a map of the implicated networks and generate a hypothesis that we would want to test with the SEEG depth electrode array. And then the neurosurgeon refines the depth electrode based plan using the ROSA software platform. And for this, what we've been using is a volumetrically obtained CT venogram with contrast to look at the bone for the registration and the blood vessels for avoiding the blood vessels during the trajectory planning. And we also use MRI with contrast to also look at blood vessels. And we also upload functional imaging studies such as DTI or resting state functional conductivity or traditional functional MRI, as well as PET studies or SPECT studies can be co-localized and fused onto the imaging platform as long as they're in traditional DICOM format. So then we target our desired areas, and I choose entry and target points looking at high value sites and margins, and then we use the software then to modify the trajectories to avoid vasculature before we do the implant. This is one example of a typical template that the epileptologist might use to help map out the general intended networks to be implanted, and this is then refined on the platform itself. So here on the ROSA platform we can import the various imaging modalities and then work with them to create trajectories for multiple depth electrodes, unilateral or bilateral. And here's just some screenshots of the software provided by ROSA, showing in this case about 12 electrodes going in on the left side in an orthogonal trajectory. So intraoperatively, the patient's under a general anesthetic, and then the head is fixated to the robot, and you have two options for registration. You can do a contactless laser surface registration using the CT scan, or you can place skull fiducials and obtain imaging, and then register the head to the robot using the bone fiducials. And we've utilized both versions so far in our practice. And then once you have the patient registered, the robotic arm and software is going to calculate the optimal trajectories to access the electrode placement. And the steps of electrode placement include a prep of the scalp, and in our cases we usually avoid clipping the hair. We just part it and braid it out of the way. Local anesthetic, we do either a skin incision or use the drill itself to go through the skin and the bone, using the robotic arm as a guide tube to give us the optimal trajectory. And once the twist drill is made, we'll then coagulate the dura and then place an anchor bolt. Then we use the robot to measure the distance from bolt to target so that we can select an electrode of the appropriate length. And then the electrode is passed through the bolt and secured with a cap, and I'll show you some photos of that. Then you repeat that for each electrode that you've planned out in advance. So this is one of our OR suites. You can see the ROSA at the center screen here, and then the patient's head is right here, and then moving out towards the feet. And so the robot is draped sterilely, and the patient is draped out sterilely. And so here's the arm with a guide tube going to our first entry site, and I'm injecting local anesthetic. The next step is to use a twist drill to make your trephination. And then once that's complete, we do a little irrigation to clear it out, and then we use a dilator to coagulate the dura to minimize bleeding. And then here the anchor bolt is placed with the provided screwdriver through the guide tube. Once the anchor bolt is placed, we make a measurement from the anchor bolt to the arm, and then here we are making the measurement. So then we can select a depth electrode of the appropriate size. At this point, the robotic arm swings out of the way under its own power, and then we can place the electrode in place and label it appropriately. And then the arm can swing back in, and you can repeat the additional electrode implants. Then here's what it looks like at the completion. Post-op, what we've been doing is we've been going with an anesthetized intubated patient straight to the CT scanner, where I get a volumetric CT without contrast to make sure that there's no hemorrhage. And if the CT looks adequate, then we're going to extubate them either in the CT scanner or in the recovery room, where they then go up to the epilepsy monitoring unit for the rest of their stay, and we're not putting these patients in the intensive care unit. Their pain levels are quite low. Most of the patients are awake and eating and reading or playing with their iPhones by the afternoon. I continue IV ANSEF until the electrodes are out. And then once all of the data is obtained and we've made a decision to remove the electrodes, I perform this in the operating room under a mild sedation. And then the anchor bolts and caps and electrodes are removed very easily, and a single absorbable suture is placed at each site. And then in some cases we're sending the patients home later that day, or sometimes keeping them overnight to get their anticonvulsants back up to a therapeutic level. And then the data is analyzed offline and electively and reviewed at our next epilepsy conference for potential planning for an intervention. So these ROSA-based SEEG strategies have some technical issues in children, but offer a lot of promise for some new meaningful investigations in difficult to access areas to record from. In our early experience here over the past year, we've performed 8 SEEG implants, and we have about 4 more scheduled over the next 2 or 3 months. And we've found that the technique appears to be safe so far and effective, and it's certainly less invasive than grid-based strategies. We're getting good quality recordings, and the patients are tolerating this very well.
Even in this initial experience, though, we've learned a lot about how to do the planning. There are multiple. The neurosurgeon, Dr. Smith, is obviously key to the process, but there are many other people involved in the process, including the primary epileptologist and the epileptologist who may be present during the case, and maybe a third person who had been there for the non-invasive monitoring. So we quickly realized that we needed precise identification of both entry points and targets, since you may get both with a single electrode penetration, and that we don't want to miss a key desire of one of the referring epileptologists to actually record from a specific brain site. So you'll see in our planning process how we've adapted some of our workflow to be very precise about these needs. And then in general, we've also approached this from a lateral entry orthogonal approach where electrodes are placed from the lateral side. Although you'll see in one of our cases, not every site in all children is that appropriate for, particularly in some deep areas in the brain, across the anterior posterior axis of the insula, for example. It does allow a more orderly approach for both planning and interpretation. So the importance of this planning and the communication is also that it has to go across both the surgical side and over to the EEG side. It's complicated to describe where the electrodes often end up because they may hit multiple targets and they may be in close proximity to each other. We also have an issue where we no longer have our nice internal reference facing the skull as we did with grids and strips. So we have to deal with referencing issues more, and therefore, as you'll see, we've chosen to go to mainly bipolar montages, referencing down the electrode, which works very well for localizing activity despite the smaller inter-electrode spacing that you have with these depth electrodes. So there are simply some epilepsy types and epilepsy networks that are much better suited to stereo EEG. So we'll present a case of insular epilepsy, which was really only approachable with this technology. And many times we have lesional epilepsy with lateralization, but not localization. So stereo EEG can be a nice adjunct in terms of really localizing what the potential resective zone needs to be figured out. And then finally, one of our other cases it may offer an opportunity in past resective cases to further tailor and assess next treatment options. So we're going to present a couple of clinical cases, then I think we'll take a pause for questions, and if there's additional time, we'll have one additional case. In one of our initial SEEG series, this was a teenage boy who I was part of the non-invasive monitoring on. He's a 14-year-old boy who's had epilepsy since age 6. He's refractory to multiple medications. So he came in, like many of our cases, for a preoperative evaluation. The preoperative ictal EEG was right lateralized, but was not well localized on scalp EEG. The MRI, which we'll show you in a moment, had a MRI-based lesion that we wished to evaluate, but from the scalp EEG we weren't clear that this was the ictal initiation site. Concordant with this was the PET, which showed right frontal hypometabolism, and a neuropsychological evaluation which showed him to be essentially typically developing.
This flare MRI axial shows an area of prolonged T2 signal here in the frontal operculum and involving the insula as well here in the coronal. And so in conjunction with the primary epileptologist and the team that performed his non-invasive studies, we worked up a plan for an SEEG implant which included coverage of that lesion specifically, which here is the red dot, which was electrode A, and additional sites that we thought might be implicated in the network, such as the cingulate and inferior frontal lobe and the anterior and posterior cingulate, as well as some of the insula. And so this is what the planning ROSA looked like for this patient. There was a total of about 10 electrodes labeled A through I. And this is just showing what they look like in a three-dimensional reconstruction off of the CT. And in this case, this is the MRI with contrast showing all of the various trajectories. In this case, all planned with an orthogonal type approach. Once they were implanted, then the patient has a CT under anesthesia, and the CT is then fused back to the plan, and then we can assess how accurate we were in terms of our placement of electrodes relative to our plan placement. So here's the CT, which is now fused and merged back into the ROSA software, and this is magnified but to show, and essentially this is a 1 millimeter error in targeting, which is within what I plan for blood vessels. I keep a 6 millimeter virtual diameter of each electrode, and I make sure I plan so I've got a 6 millimeter margin for any blood vessels. So a 1 to 2 millimeter inaccuracy, either due to registration or drilling or placement, is acceptable.
So one of our biggest challenges was to break out of our what I call strips and grids workflow and go into SEEG. And one thing I had to learn was that I'm not the only one dealing with this data. I'll have to present it to people that may not be involved with the case. So we played around with various methods of visualizing where the electrodes are in a way that we could put this on a piece of paper, really. So this is an earlier case. So I labeled the CT, a 3D of the CT with the colors, and also with the letters that correspond to the EG channels and the ROSA plan on a CT. This is just an example from one of our presentations. And then, so one thing we had to deal with was trying to understand how we can montage these studies, in particular those that are much higher channels. We were used to up to 128 channels. Now we'll be dealing with much more, many more contacts than we're used to. And so simple things. This is just an example of standard recording montage, that not the bipolar, and putting these labels on the channels just to show, have them show better in conference. Now this is the same study in a bipolar montage, and it really cleans things up. You can see some details within the recording that were there, but not as not as obvious, I guess, when looking at it. So we did mess with the colors a little bit. We changed this to black, so if there's some difference in the screen before. But actually up here at the very top, in A, it's a darker red color. You can see this nearly constant interictal that's up there that wasn't really showing well in the standard montage. So we've also played with montages in that we don't display all the channels to focus on different areas of where the coverage exists, and in particular what areas that look at, have high yield, interictal or ictal. And then something we've been doing for a long time that actually, thankfully, we've been doing because it works very well with SEG is aggressive filtering of the EG. So this is the same screenshot, same EG, same timescale, with a 70 hertz low frequency filter, 70 hertz high pass, and it really makes things stand out and focus on the important parts of the recording. Now, with regard to filters and timescale, this I think is a good demonstration of how much this can change the EEG. So what we have here is a screenshot of an ictal onset, a seizure onset. And while, once you see it, I think it becomes apparent. When aggressive filtering is applied, and also changing the time scale, so this is now, that was a 15-second time scale, this is now a 60-second time scale. With aggressive filtering, you could see the ictal onset up here in the area, in what was our area of interest in this A contact, A electrode, in the more distal contacts, and you can see the spread of the seizure within the different contacts in the context of many electrodes. And this is just a reduced screenshot. Normally this would be very difficult to show.
So as a result of the SEEG, there was a well-defined localized epileptogenic area identified. The family was offered the option of laser ablation versus a resective strategy. I'm pleased to report that after many months he's seizure-free, function is improved, and the family's very happy.
There are a few different guidance platforms for delivering laser fibers intracranially. And there's two main laser ablation systems that are FDA approved, and those include Montage and Visualace. This is a Montage system, and we've adopted the ROSA to hold the laser probe itself. So this is a ROSA guided laser ablation of that frontal opercular lesion. And this is the intraoperative image showing the laser fiber coming in, and here's the area of necrosis around the region. And this is just showing the MR thermography. Here's a orthogonal view of a coronal coronal T2, and we basically replicated the trajectory A that we had used on the initial ROSA plan to do the intervention as well.
So I'm going to present a second case, so we're moving on to the second case. This is actually my personal patient, and I've been involved with her care for a long time, including in my epilepsy fellowship with her first grid. She's now 20 years old and has had nightly seizures and daytime seizures, but every night since 6 months of age. Multiple medications have been ineffective. I've tried her on essentially everything that I can, and very few of the medicines even make a dent in her seizures. She had a grid placed at age 4, mainly over her lateral cortex. Again, a grid just picks up surface activity, and as a result of this she had a small topectomy and multiple subpial transections, but this did not impact her seizure frequency one bit. A few years later, as part of a surveillance MRI, a lesion was noted in her insula, and Dr. Smith, as you'll show, approached it with gamma knife. And this has been the only real reduction she has had in her seizures ever since then. However, after many years, her family, with this new technology, wanted to try some additional therapy.
About 8 years ago, one of our MRIs showed this area of vague enhancement with some T2 abnormality, and we actually performed an open craniotomy and biopsy, and were suspicious of a cortical dysplasia. And then, for fear of a large deficit from a dominant insular resection, we ended up trying gamma knife to this region. And she did have significant improvement in seizures, so we felt like we were close, but then her seizures recurred. So Dr. Zimpel requested an SEEG evaluation, and in this case we had planned some trajectories with a lateral orthogonal approach to the operculum and insula, as well as some oblique approaches, taking into account her multiple prior surgeries. This is how everything looks on a three-dimensional reconstruction intracranially, and one of the things you need to do when you plan is to avoid intersection of these electrodes. So these are all coalescing in that region of signal abnormality and prior biopsy and prior radiosurgery. Here's again how the implant looks during the planning stage on the ROSA software platform. And then here's when we turn things over to Mike to try and make sense of this for something that can be presented in a two-dimensional format at Epilepsy Conference.
So this is a good slide for us because it shows how we've changed some of our planning and how we present some of the data. So one thing I had done before with our strips and grid cases, works I think really well with the SEEG, and again trying to visualize things, is just CT image, rotating it, finding a good angle, and maybe coloring the electrodes to match either the plan or the EEG color. And also you see at the bottom here, this is what we do in the OR to keep track of these electrodes. And one thing I did want to mention is, despite the increased number of, say, contacts and maybe electrodes that we have with the SEEG, it's actually much easier to keep track of because each electrode has a serial number and it's very easy to identify for the technicians what they're hooking up when they plug each electrode into the amplifier. So before we were left with different color combinations and things, and we found that you really can't mess this up. So this is an example of this patient, and we actually had surface EEG electrodes on at the same time. And this is an example of before we used bipolar montages in this case, and we see this interictal activity, and you see some, I guess, what looks like an active reference, and you also see a correlate of this discharge on the surface EEG that we had at the same time. So it's just a zoom here. So what really came in handy with this patient was our use of filtering and being aggressive with that to try to help localize our activity and also with trends. But so this is a 15-second screen, just standard filtering, 70 hertz to 120 hertz. But so this is a 70 hertz high pass, and it helps sort of visually show you what areas are most active. And then this is a very aggressive approach, but it helps visualize this area well, and in the next slide you'll see what I'm talking about. So you see these dark bands here, so this darker green, this I guess lighter yellowish green, and this red color. This is at the ictal onset, which was just about at the top of the page, and you can see this leading in, and then the evolution of the seizure within these key contacts. So what I had done here, and it may be hard to see, is that, and I in hindsight would have picked maybe red or something, but I had labeled the contacts that were that high frequency activity was in. And looking at the EEG, you don't really get a sense of how close electrodes are. So in the CT, we label the contacts that are most active after we have enough data, and then we can spin them around and see how close they are in space with each other. And it also makes a good picture for our conference for the folks that weren't involved in the case. So I'll turn this over.
And this is another immediate post-op CT where we can fuse the actual electrode implantation with the planned site. In this case, we're essentially overlapping even with a nearly 200 or 170 millimeter long electrode pass, and it's going down pretty much down the planned target length. Same with this one and this one. And these are all intersecting in that same region of the insula that we were suspicious of. In this case, we offered an open resection or a laser ablation of the insula, and the family elected for a less invasive approach. And this laser ablation was performed with 2 oblique passes from an occipital approach, one above the other, to ablate the insula first inferiorly and then superiorly. And so these are the thermography images during the ablation. Then here's the post-ablation of the insula MRI T2 showing the region of resection or ablation.
And I'm pleased to report that her mother, when I last saw the family, was so happy because she's now slept through the night for the first time since this patient's been 6 months old. Her main seizure type, where she's screaming out of sleep, is completely gone. We did some post procedure EEG, and she's not having any active seizures, and so her scalp EEG is much quieter and she's functioning much better. So this was a case where we just didn't have a good way to address where her seizures were coming from prior to our ability to have these very, very deep areas of the brain monitored.
So we're going to pause now and see if anybody has questions about SEEG in general, ROSA in particular, or those 2 cases. I think those could be viewed as, their management is somewhat controversial, but certainly there is a lot of different ways to tackle those last 2 cases.
So this is also one of my patients. She's an 18-year-old who just went to college with focal epilepsy. She's had seizures since a very young age, and she's profoundly drug resistant. This is an example of someone who had a prior procedure And because she had an incomplete resection, her parents did not want to take out her hand motor area, she continues to have nightly seizures. So the question was, should we perform further resection? Should we start using responsive stimulation therapy through a NeuroPace device? We kind of redid her epilepsy pre-surgical workup, and her PET might have been a little bit more posterior. We obtained a MEG, which we'll show, and kind of concerning was sometimes she has more of a sensory aura first, although with motor seizures that can be complicated.
So this was from a traditional grid-based evaluation 10 years ago, and I did this grid with Dr. Zempel in 2006. And so this is a right-sided approach. This is the sylvian fissure on the right. This is the temporal lobe. This is the frontal lobe. This little black suture demarcates the central sulcus. This was wrist extension, and this was a contraction of her nasolabial fold. So the face motor region was here and hand motor was here. And we put down an array of grid and strips for frontotemporal parietal coverage, and ultimately identified her ictal onset zone as encroaching on face and hand motor. And what we elected to do was a largely parietal resection with some MSTs in the motor area. Postoperatively, she had a mild hemiparesis and some facial weakness, which recovered except for some very mild, persistent, really hardly noticeable facial weakness years down the road.
And as part of her evaluation, I'm showing some data we obtained from the Medical College of Wisconsin where they performed a MEG scan. And this showed her interictal epileptiform activity had a dipolar map that was in the posterior part of the resection margin and behind the resection margin. If her epilepsy is coming out of this area, it's potentially further resectable, and hence we went to evaluating it with stereo EEG.
So ultimately here was the plan we devised for this patient. We wanted to cover these parietal regions that were active on the MEG. I didn't load this for the webinar, but we were able to load the MEG dipoles onto the DICOMs and target the dipole clusters, which largely were behind the area of prior resection. But we also were worried about the motor strip, and so there were additional electrodes that were placed directly in the precentral gyrus in the region of face and hand, so we could identify if onset occurred there as well as map those locations. And then there was also an orthogonally positioned electrode along the long axis of the insula so that we could record medially, posteriorly, anteriorly, and superiorly to the prior resection. The SEEG implant took about 2 hours. It's about 7 minutes per electrode to do the implantation, again with minimal hair clipping and a fairly comfortable patient after surgery.
So the data for this patient was challenging in just that there was lots of it, and there were many contacts and different areas that were active. And this is, I guess, an example of a more mature plan that we have that we use to visualize the EEG, and that we combined all the things that we had been using to be able to keep track of where things are and for demonstration. So we have just a CT with color labels, and you know, we keep the EEG channels labeled to match the ROSA plan because it makes sense. It's alphabetical. It's just everybody is on board with that. And then we have our little 3D, the MIP, where we also label that, and so that's what this is showing. And the next slides, show just again, this patient's too complex to go over all the EEG, but one thing we do in the lab, and we found very helpful with SEEG, is using the trends. Our EEG software has built-in trends, although we've used third-party software too. But just to give you a bigger picture of the EEG, you're looking at this at 15, 30 seconds maybe. But in this particular case, this area here, the pink, this interictal area, became very active during the day, and it was we highlighted these channels. So J and J, this is H, and then J, and I included these in this trend here, and you can see all this activity. Those are these bursts here, and how they, when they calm down or even get longer. And so just for accounting and being able to keep track of the patient and how active they are, we've used trends for that. And most importantly for us, seizure comparisons. This helps me a lot when trying to figure out a patient, just to line them all up together to see if there are any differences or what's consistent between seizures. And you can see how complex this is. These are long time scales, 30 seconds to a minute or so, with lots of filtering, and you can see all the activity. You see these two top seizures are similar. This seizure down here has a bit of a different pattern with J, and this one here is different yet, still. But putting them all together, using all the tools that you have for reading EEG, and strips and grids, time scales, filters, different montages, can help you make sense of what might appear as daunting as far as the amount of channels and locations that you're having to deal with, that you didn't have to deal with strips and grids.
Another example of the post-implant fusion confirm that we're, where the intended target was.
And in this case, our question was whether we had a potential resective zone posterior to her motor areas, her motor cortex. We recorded seizures arising from multiple areas, both anterior and lateral, or mesial and posterior to past resection margins. As part of the SEEG study, we were able to map her motor areas through the SEEG electrodes and know that it was primary motor cortex. As a result of this, the family decided not to choose a resection because it would have invaded her motor cortex. This is a young college student who really values having some fine motor movement of her hands, as she works extensively as a seamstress, and that's very important to her, so she didn't want to sacrifice that ability. The nice part is now we've got a plan from the SEEG electrodes of where to implant the NeuroPace electrodes. So even though we weren't able to precisely offer her a total home run, we're able to use this to prove that what we're doing is the correct thing for this patient, and it helps guide us in the further planning of how to approach her epilepsy.
So that was the final case that we prepared to formally present. I did see that there was a question about the use of grids with SEEG, and have we done that? The answer is we've not done combined grid and SEEG cases at this time. We do have some patients where we did an SEEG implant, with the idea being we wanted to refine the area to place a grid, and then there'll be an additional stage of a traditional grid-based resection implant and mapping. There's nothing that would preclude you from using ROSA in the context of an open craniotomy and use the trajectories to guide placement of SEEG electrodes, although you wouldn't be able to use the anchor bolt if they were within the area of the grid itself. But you could design an implant, for example, to implant the insula using ROSA and then do a traditional grid laterally, for example. So it's a flexible system in conjunction with an open craniotomy. You could envision ways to utilize SEEG to augment a surface array.
I think one of the key concepts we have to change to, though, with SEEG is that SEEG, because it's less invasive, because it's so much better tolerated, is on the order of an ictal spec, where we want to obtain more seizures, obtain more information, and if it makes sense, do a resection. And one of the huge advantages of SEEG, for example, over ictal spec, is we get multiple seizures recorded. So we get to see not only where one seizure is coming from, but many. And I think we shouldn't quite place SEEG quite at the same level as a grid and strip case. Rather, it should be viewed as a way to get more information about the patient, and some of those patients are still going to need to have grids and strips. For others, it may be more definitive. But since it's so much better tolerated, I'm very much more willing to put my patients through such a procedure, even if their chance of seizure freedom isn't 70% or 50%, with the hope that if we study enough patients that will help those who can truly benefit. Are there any other questions on the phone line?
Just a question on the neuropace. Have you implanted that patient yet, or she's not yet been implanted?
She wants to finish her college semester and is planned for over the winter break.
And will you utilize ROSA for that, or do you tend to do that independently? Have you used ROSA and neuropace together before?
This is Matt Smith. I've done 2 NeuroPace implants, and those have been surface strips on kids with Broca area onset. This will be the first depth that I've done with NeuroPace, and we're going to utilize ROSA to place the depth electrodes. In addition to the 2 primary ones which will be attached to the NeuroPace device itself, we're going to go ahead and implant at least 2 extra ones that were close by regions of interest, so that if we do want to come back and switch those 2 auxiliary electrodes onto the primaries, we'll have that option. And yes, we will utilize ROSA to place it, since we already have the targeting plan all set up and we know where to go.
Excellent. Thank you.
Hi, this is Perry Schweifert. I'm the product manager for the ROSA robot. My question is, actually on this last slide that's up right now, mapped motor with SEEG electrodes. So this is a concern that we hear quite a bit with both surgeons new to ROSA and new to SEEG. And, you know, some of our old school surgeons have even said, you know, they're never going to get totally away from script and grid. They may use SEEG to determine a seizure focus, but they'll still need scripts to map the motor cortex before a resection. Can you sort of expand a little bit more on how that process worked, and if that was something that came easily, or sort of something that had to be more grown into as a group?
Yeah, you know, we're still in a learning curve. We're still in our first year utilizing SEEG and doing mapping. With respect to the mapping being performed in the EMU with the implanted SEEG patient, it's quite similar to grid-based mapping. We're using the same stimulator, we're using similar currents, and we're cross-checking electrodes with each other to get a stimulation. The comment that a grid is necessary to map motor, I think, is becoming less dogma because of advances in functional imaging. Here at WashU, we do a lot of passive resting state functional connectivity mapping in conjunction with DTI, and when you utilize those modalities, you have a pretty firm idea where motor is. And when it comes time to do a resection, you can do intraoperative mapping to identify motor. But no, this does not completely supplant the potential need for a grid-based evaluation. And I think if you have a patient with a perirhodontic onset, you probably will consider gridding that patient for a more finely detailed map before doing a resection. You want to add anything to that, John?
No, I think I agree with that. I think it's not one versus the other, but it's one, for example, SEEG if it helps you focus your coverage, and if you really need to map primary language or primary motor, grid is an appropriate solution for that. But again, I think the issue is that it's simply so much better tolerated for those patients where you don't know where their focus is, or you think you've got it somewhat localized. It can be very helpful for your grid planning to have a much better idea of where you really strongly suspect the focus to be. The frontal lobe is a very large lobe, and even with grids, it's hard to cover all of it, so it's really helpful to have more precise information.
Yeah, and you would never use SEEG purely to map. Would you follow up SEEG?
I think if you needed electrophysiologically defined precise margins, SEEG probably isn't enough for those cases, but it can get you close. So if your resection strategy doesn't need those precise margins for whatever reason, then SEEG can be enough. It can confirm that you're in motor cortex, which for some resective strategies, you're not trying to figure out exactly where the margin is. You just want to be certain you're away from it. It's why we try to cover primary motor cortex with all of our grids, even if they're more posterior or anteriorly, simply so we know where we are.
Yeah. Great. Thank you.
And there was a question about software.
Yeah, I'll just answer it. I was going to answer in chat, but so somebody had asked what trending software we use. Right now, we actually just use we have Neon Coden as our EG vendor, and I found that their built-in trends work just fine for what we need right now. We have used Persist. We do use Persist. Persist is typically used in all of our studies. We just haven't done it yet with the SEEG, and we probably will move toward that just because we can get a finer look at the EG. But for basic screening, we're using this because it's recorded with the EG and it takes no effort to set up, and it's been helpful. So.
All right, everybody, thank you for attending, and we wish you a good evening.
Thank you, you guys. This was excellent.
Thank you. Thank you very much.
You're welcome.
Take care, guys.
Bye-bye.
Yeah.
Bye-bye.
Bye, everyone.